Am I audible?
Yes, sir.
Can you see my screen?
Yeah, make it full screen, sir.
Yeah, I'm doing that. Yeah, is that right? Okay.
Yes, sir.
Good evening, ladies and gentlemen. Welcome to this panel discussion on getting started with clinical research. We really are blessed with a very accomplished panel today. Professor Ramanuj Mukherjee, Professor Vikram Kate, and Professor Pawanendra Lal, who are really stalwarts in the field. I request all of you, the audience, to put your comments and questions in the chat box. Please keep them short and succinct. We will try and take as many questions as possible. I request my panel to assist me in case I miss any questions in the chat box. In fact, I find that I'm unable to see the chat box, so I request Ramanuj to please monitor the chat box. Yes. And I also request you to kindly answer the questions in the chat box so that in case we miss some questions, we would have at least answered them in the chat box. It's a very vast subject, and we would like to touch upon 4 important aspects of this wide topic. Why do research at all is an important question we have to ask ourselves. Choosing a topic for a research study, what should be the type of study that one should choose for a given research question, and the most important document that we all have to prepare before doing a research project, which is writing a protocol. Let me straight away say that for the purposes of this panel discussion, we would like to look at research and writing paper and research and writing a thesis as one and the same. There are very small differences, but we would like to address postgraduates who are embarking on having a project for the thesis, as well as a young surgeon who is embarking on a study to get a paper out of. As I said, we really have a distinguished panel. Professor Ramanuj Mukherjee is a professor of surgery at Ajikar Medical College. He is an EC active, EC member, and a top-class quiz master, as we discovered yesterday. Professor Vikram Kate is one of our most accomplished academic surgeons with a huge publication list to his credit. He is the professor at JIPMER Pondicherry, and as you can note here, he's actually written a book on writing and publishing a scientific research paper. Professor Pawanendra Lal, I had the good fortune of meeting him several years ago as a fellow examiner at the MRCS of the Royal College. I also learned a lot from him about setting up a clinical skills center. And I actually, from the learning that I had in that encounter, we set one up in the Bangalore Medical College. And today, apart from his excellent academic output and his teaching capabilities, he is heading the National Board of Examinations. And this is me, Dr. Lakshman. I'm a consultant surgeon in Bangalore, and I teach the postgraduates in the DNB stream. Now, it is very, very important to ask ourselves why one should do research at all, particularly a postgraduate who is embarking on learning the skills of surgery, would obviously be focused on the skills of learning, skills of surgery and learning the theory behind it. Why would research come into the picture? A young surgeon who is embarking on a career as a surgeon would like to know, why should I waste my time on research when I have to spend the limited time I have in establishing my practice or establishing myself in a given unit? I hope in the next 7 to 8 minutes, I'll be able to answer this with some degree of clarity. This is a statement from Thomas Friedman, an economist, a journalist, and a writer who was in Bangalore a few years ago and said, looking at the IT industry, that he felt that the world was flat. What he meant was that what can be done in the real Silicon Valley in California can be easily replicated from Bangalore, the Silicon Valley of India of those days, and said it is done at a much more efficient and a much less expensive manner. And so you it was natural that people would precipitate towards India for their IT needs. In a sense, he was saying that in the IT field, as far as he was concerned, there was a level playing field between these two areas. What a level playing field essentially means is that you have a lot of opportunities, but mind you, it brings in a lot of responsibilities as well. Now, can we really say this about the scene in Indian surgery? That is a question we have to ask. And my answer is through this paper that we published last year in the IJS. We looked at the surgical output in the country. We form a fifth of the world's population. There are 75,000 surgeons nearly, and we do a lot of surgical work. But then if you look at the top 5 journals in the world, as far as surgery is concerned, top 5 based on the impact factor. One may question that that's not the only factor, but it is one of the factors that you consider for grading a journal. We found that we had very few publications from India in that. In fact, World Journal of Surgery was the one with a reasonable number, 27 out of 2,100 articles totally published. And even in our flagship, which is the Indian Journal of Surgery, just about half were articles from India. And it is a little interesting and perhaps humbling to note that even China has a lot more publication. I say that because we must note that their expertise with English is perhaps much less than ours. And this statistic was a little startling. 57% of medical institutions do not have a single publication. Now, what are we looking at when we look at a surgeon? Goals of training, which any society would like, is to have a safe surgeon who practices evidence-based surgery. He should be a thinking surgeon, not doing things mechanically, but has the capacity of what is called the HOTS, the higher order thinking skills, who would work his way through difficulties that he faces in his everyday life. And of course, he must be ethical. And so to meet this requirement, we don't talk about, if you see nowadays, not just continuing surgical education, but we talk about continuing professional education or professional development, which goes well beyond just surgery. It means some degree of proficiency in research, communicating skills, even your accounting and tax issues and the like, and you are a man management person as a leader of the surgical team. So you must have good knowledge, basic knowledge of human resources. Now, we talked about evidence-based and thinking surgeon. What is the fundamental requirement for being evidence-based and for being a thinking surgeon? Critical appraisal of any document, any scientific document, is an essential requirement. When you read a paper, when you read any surgical information, you need to know whether that is scientifically valid. And for you to have the skills for critical appraisal, you need to have some knowledge of research. Now, evidence-based medicine, again, this is from the original work of Sackett. Evidence-based medicine and surgery are about the same. It is just the discipline that is different. It is based on relevant scientific evidence. And that is where the value of the papers the communication that I talked about comes in. But it is not just that. There must be a clinical judgment, and there must be a factoring in of the patient's preferences. That is very important. But this is where we lack. If you can see the relevant scientific evidence, we need to produce our data. There is really very little wisdom in trying to mimic or take information from foreign journals. Their genetic stock is different, their working environment is different, and their disease patterns in some of them are different. And so we need to have our data. And again, why else should you do research? Not just to know about evidence-based surgery, but you learn the discipline of documenting your work. You learn the nuances of analyzing the data in a scientific manner. Above all, you conform to international standards. Whenever you go and meet people from elsewhere in the world, the first thing they ask you, are you published? Have you put papers and got publication in peer-reviewed journals? And if you say yes, your stock goes up then and there. It also helps you to be very, very truthful and factual. And through research and a close cousin of research, which is an audit, you have the great tool for self-improvement. And as Mrs. Modi said, without inquiring minds, medicine will come to a standstill. And that is something we need to have inquiring minds. We need to keep analyzing why we do what we do. And that is the only way we can progress as surgeons. Martin Schein put together the list of things that one should do to undertake research and publication. The altruistic motives may or may not be in everybody. Dissemination of knowledge, a kind of focused work in a given area. These may not be everybody's cup of tea. But then you also have egoistic moves. I think we can write away this financial gain, because hardly anybody in India would have a financial gain through research project. But it happens in the West. But then you can see that academic promotion, professional promotion, you're standing amongst your peers, your capacity for judgment, which is an extremely important factor for clinical success in what you do. And of course, the ego of being known all around. And of course, the development of a network which has direct and indirect advantages in your being a surgeon. These are the factors which I think are extremely important and which should motivate every one of us, whether you're in a medical college, whether you're in private practice, or whether you're a postgraduate student, to try and learn doing basic clinical research. Now, this is my last slide. This is Salter's list of the qualities of a scientist, a person who would undertake research. Please note that among all the 8 I's that he mentions, integrity tops the list. My appeal to all the youngsters here is that bad research with cooked up data, is much, much worse than no research. So what is required when you undertake this journey, which is a beautiful and very interesting journey in research? Being in private practice, I have enjoyed myself doing a little bit of research. I've had a few publications under my belt. It has been a great journey, and I would like every one of you to have that journey. But please remember, total and brutal honesty in your data is a requirement. Thank you very much. I will stop sharing my screen here, and I now invite Professor Ramanuj Mukherjee to talk about choosing a topic in research. Professor Ramanuj Mukherjee, please.
Hi, very good evening, sir. So is the screen visible now?
Yes, Ramanuj.
Hello.
You are heard well and you're seen well. Please go ahead.
Thank you. Now, a very good evening, everyone, and a very good evening to my co-panelist, Dr. Kate and Dr. Lal. Okay, with this, ladies and gentlemen, I think we'll be discussing an important topic to begin a research, that is how to choose a topic for research. Before I begin, I would like to convey my sincere thanks and gratitude to the whole leadership of the ASI for the opportunity to be in front of you, and particularly Dr. Santosh John Abraham, Dr. Ravi Dalvi, Dr. Siddesh, and the rest of the scientific team. Greetings from the city of joy, Kolkata, and as with the rest of the world, we are gradually coming back to academics as well as surgery. Now, whenever I teach bright young minds, surgeons in training, about how to start a research, I always tell about an incident around 3 centuries back. And at those times, there were no nuclear missiles and aviation was not known. So ships or naval power was the most important thing in a colonial culture to conquer countries. And the Spanish Armada was the forefront in the Atlantic. The British Armada tried to take over, but as you can see, the number of the deaths around 1 year was 1900. But what was very interesting was that in that year, 1400 out of this 1900 did not die out of a warfare, they died out of a disease called scurvy. I have a bad handwriting. And what was interesting was that a doctor on the ship by the name of Dr. James Lind heard that having lemons for food or as a part of the diet could help in treating scurvy. And as a part of one of his trips on a ship, he did an interesting experiment. It was called as an experiment at those days. And out of them, 2 sailors were given with the usual diet 2 lemons. And what was more interesting was that his stock of lemons ended in just about 6 days. But in that brief span, where the rest of the patients did not have any improvement, this gentleman had rapid improvement. He left the job, published his data 6 years down, but started with something called as a clinical trial. Now, as Dr. Lakshman has already told you, the reasons why you should think about doing a research with altruistic moves and definitely with some other ones as well. My job is to start to make us all think about that whatever you have in the front is something called as a life cycle of a research. And my job is to now make you understand what is the basic thought that goes on to make a research that is a research question. So the first thing that comes to everyone's mind is, what is the topic, sir? What is the idea? Now, as I've said, everything in the world has begun with an idea. And where will you get an idea where to start your research from? First one, as you are a surgeon, you may have had your experiences and you now want to improve your experiences and practice. Number 2, you go to conferences like the one that we are sitting in, which is an international one with delegates across the world who are watching us. So you hear experts, you even have notes from conferences and come back to your place. You will consult books, journals, and definitely the internet, but probably the most important gentleman or the lady down the line, if you are a surgical resident, will be your guide, will be guiding you for the next 2 or the 3 years into understanding what is a research, or technically called as a guide or a co-guide into this. Now, whenever we guide our residents or whenever we think about any idea, the first and the most important job that we do is that we train our thoughts into a criteria that is called as the finer criteria, standing for feasible, interesting, novel, N-O-V-E-L, not N-O-B-L-E, ethical, and relevant. So if you have these ones, then I will tell you an incident around 2 years ago when one of my residents went to a hernia congress and came back very excited, seeing it was around a 2-day congress. And this gentleman sat around the whole congress and came back to me on a Monday morning that, sir, I'm very excited after the congress and it was really a good one. Why don't we do some thesis work or some protocol writing based on this? The first thing he got very impressed was with robotic surgery. He said, can I do this in this hospital? Well, sir, not very practical because I'm not a robotic surgeon. Is it interesting? Yes. Is it novel? Yes. Is it ethical? Yes. But the question in an Indian perspective is that, is it really relevant where many patients are still waiting for a Lichtenstein's repair? He told me the next one for the testicular biopsy findings in humans and primate models. I said, whoa, man, great, interesting topic. And that also after someone has put in a mesh in the groin. Is it feasible? I had a big question mark because the animal lab in charge told me, Ramanuj, it is difficult to get primates in the institute. So, well, it was not an easy one. Is it interesting? Yes, I was very interested. I'm very interested in basic research. Is it novel? Maybe. I'm not very sure of it. Is it ethical is a big issue because you are now dealing with human beings in the post-operative period taking biopsies. I'm not very sure of it. Is it relevant? Yes, maybe, but I'm not very sure whether it is going to change the practice. So he came up with the third topic in which he heard about Dr. Desarda's name, and he heard about that there was some comparison of a Lichtenstein's repair and a Desarda's repair. And he told me, and I find that yes, it is very feasible, and I really like the technique of Desarda's repair. Is it interesting? Yes, I'm very interested in doing an innovative step. Is it novel? Extremely yes. Is it ethical? Yes. Is it relevant to an Indian practice? I will say 3 ticks to this because it is very relevant. Now he told me, I have also seen laparoscopic repair. So why don't we do a comparison? We are doing open and laparoscopic hernias. So don't you think we can do this? It will be an easy one. We get too many cases. I said that, is it feasible? Yes. Is it interesting? This is the point that I beg to differ. Is it novel? Well, it has been proved over the last 25 years. Is it ethical? Maybe. Is it relevant? Probably not, because there are guidelines now, hernia search guidelines, which are published comparing both. So I think now we have a brief idea. So we now needed to put it down in a pen and paper. And so what we did was we wrote it in a style called as a PICO format, or technically a PICO format, standing for population, intervention, comparison, and outcome. And then with the same data of Disarda versus Lichtenstein, we went on to make the patient population, the P is a patient population, as hernia patients. Intervention was the Disarda, comparison was the Lichtenstein's group, outcome was something that was not mentioned, maybe recurrence rate, and the time period, it did not have 5 years, but I intended to do it for 5 years. So we modified the topic to have a 5-year recurrence rate between Disarda and Lichtenstein's repair. So in a similar note, if you are understood about Dr. Lin's experiment, then you may have now a PICO format for that one also. Now, how do I search or make this PICO format useful? So for that, what I do is that I go to the Google, search about the PICO search in PubMed. As you can see, it opens up a page, and in this page, it looks like a calculator for all of us. So what I will do is that I will type in the condition called as a hernia. I will do the intervention called as a Disarda. I will compare with what one called as a Lichtenstein. Okay. And what is the outcome? I have recurrence as my outcome, and then I will submit the data. So what will interestingly come out is, as you can see this, there has been 12 results with the PICO format, and let us have one such to have a full text, and you will now get an idea about how the research is done. So with this idea that if you have these ones, then my second last slide, what shall you read after today's panel and symposium, which is very important and is probably a life-changing symposium for many residents. The ICMR and the NIE conducts an excellent course in biomedical research, and I hope you are a part of it. And it is important for the National Medical Council that all residents and consultants should be taking this important course. Lastly, as I always say, for your guide, maybe choosing a topic can be very easy. But for you, as you have said, all the topics may look very interesting. But for a guide, he has or she has years of experience, and it may look very lucrative with the topic. So please choose a topic which follows all the criteria, because your research is going to depend on this. With this, thank you very much. Thank you for the opportunity to be in front of you. Thank you, sir.
Ramanuj, thank you very much for your very lucid, very useful presentation. We will take the questions at the end. I haven't seen any questions in the chat box anyway, so we'll go ahead with the rest of the panel discussion. I now invite Professor Vikram Kate to talk about choosing the kind of study that is required for a given research question. It is very important that you use the Finer and the PICO criteria and choose a topic. Equally important that you spend time on choosing the kind of study that you want, getting a sample size organized, trying to see that your infrastructure will support that kind of a study. And I'm looking forward to Professor Kate. Sir.
Thank you very much, Dr. Lakshman. I hope I'm clearly audible.
Yes, you are, sir.
Yes, sir.
Yeah. Fine. I'll just share my presentation. And
seen as well, sir. Very well. Thank you.
Thank you very much. Thank you very much. This basically it's talk a little bit about study design, and we'll just discuss in short how do we determine the type of study in this panel discussion on getting started with clinical research, the symposium on the same. Now, when it comes to study design, simplicity and clarity is very important because somebody says, if you want to understand a paper, when you're feeling sleepy, if you can read the paper and understand the crux of it, then that's actually a good paper. That is what somebody mentioned. I remembered the line and I thought that's a very good way that when you're not at all attentive and you understand the paper clearly well, it is a well-written paper. So what is the study design? So overall strategy chosen to logically assimilate the different study components so as to effectively address the research question. What is very important is that it is determined by the research question and not the other way around. This is a very important slide that the scientific integrity of the study and the credibility of the study completely depends on methodology, and the methodology depends on the study design. Now, if you look at the different study designs, as you can see here, the bias reduces and the tops. At the top, we have the randomized control trials and meta-analysis and all that. Everybody would like to do an RCT, but is it always feasible? So these are the basic types of study designs. We have basic studies, observational studies, which can be described, which can be divided into descriptive and analytical studies. And then we have what we call it as experimental or interventional studies. So this is what is the study designs picture. And here we sit. If you see this is the investigator in a case control study, it's a retrospective study, investigator is in the present and the study is done in the past. When we talk about a prospective cohort study, the investigator is present, study is done in the future. And in a retrospective and prospective cohort, the investigator is in between. You have some component in the past and some component in the future. So what are observational studies? Observational studies broadly are actually divided into descriptive and analytical. Whenever you don't have a comparative group, in those circumstances, we call it descriptive, especially case report, case series, cross-sectional. Whenever it's analytical, we have case control and cohort studies. So this is what it means by descriptive study, what it answers. This example will give you. Like this is one of the largest series from our country and in the world, because corrosive stricture is more common in India. You can see there 30 years experience, 109 patients. And what we found out, that these are different types of strictures. So this is very useful in management. Similarly, if you see this is another one for almost 3 decades or experience, 100 patients. And we can see the morbidity and mortality and all the complications are given there. So although it's a descriptive study, no comparison, data analysis, but definitely we can see that a very detailed algorithm has been formed based on this experience, which is very, very used in clinical practice, very, very commonly used and very important and useful. The other type of study, what we see are, these are called as prevalence studies or the cross-sectional studies. What is important here is that the exposure and outcome we see at the same time, although we might not be able to see a temporal relationship between the exposure and outcome. And this is a study, this is one of our earliest studies published from a country on the prevalence of H. pylori infection in upper GI disorders. And this is what the information we got. You can see here, this is what that duodenal ulcer is more common, significantly more common in control. So this is again, although we have a control, but ultimately it's a single group and there was not much analysis in this. When it comes to analytical study, comparative group is there. We have case control study from outcome to exposure, and we have a cohort study from exposure to outcome. So some examples and the advantages we'll see. Now, when it comes to case control study, we have, as I said, we have a control group, and basically these patients, we classify it as a retrospective case series where we have the outcome, we take the patients with disease, without disease, and try to find out the exposure, which are usually classified as risk factors. You can see this example of the study, that's colorectal carcinoma patients with studies, the risk factors. It was a case control study from South India. And these are we wanted to actually particularly highlight the dietary factors. These are the factors what we found were actually associated with colorectal cancer. So we had colorectal cancer and no colorectal cancer patients controls were taken, compared this dietary profile, and then got the reply. So usually in case control studies, the analysis is done on the basis of odds ratio, part of statistics. I'll not go into details of that. Now, if you see this study, this is again a case control study, slightly different from the previous one. Here in the same patient, we had studied estrogen and progesterone receptors in patients with esophageal carcinoma, in the cancer and in the surrounding normal esophageal mucosa, NEM, normal esophageal mucosa. So we all the other parameters actually were controlled here. So because it is the same patient, and this was a different type of a case control study. The estrogen receptor status, beta, and all those things were studied in this study. As opposed to a case control study, which is a retrospective study, you have to go get it from a database. We have cohort study, which is where a cohort is actually followed over a period of time. Here we have the exposure with us, and we would like to find out the outcome. So this is suitable for a disease with shorter course, and the temporal sequence we actually can find out. It's easier to match a cohort for confounding variables. It's something like actually not very much different from a interventional study. And nowadays we have a different type of design that is called as PSM. That is, we call it as, we actually match all the parameters in both the things. And then it's called propensity score matching. And it can actually give you the results, something like from these observational studies, you can get results, something like a randomized control trials. It's not an interventional study, but you can get in propensity score matching. You can get the information like that. Here, the outcome is measured in relative risk. The earlier one I said, it was in odds ratio. So just look at this example that in patients with phrase procedure, what happens to the islet cell functions? All patients who underwent this operation, these are the parameters which were tested. And this is before surgery, after surgery, a follow-up. They called that classified as longitudinal studies. The name for that cohort study is longitudinal studies. And this is the outcome, what we got. Sometimes, very rarely, we take a retrospective cohort. This is actually a combination of retrospective and prospective cohort. Is one of the earliest studies in the world on H. pylori eradication, ulcer recurrence after simple closure of perforate. Only one study before this was published in Annals. So here we can see that apart from prospective, we had a retrospective. We call back patients, okay, who had perforation 5 years back, and then we studied in them. So apart from these study design, is there some other study? Test of diagnostic accuracy. You want to test a new test against a gold standard, where we see sensitivity, specificity, PPV, NPV, and all these things. This is done with the help of ROC when you actually are using a continuous variable. So this is what is the advantage. You have to have a standard gold standard and then compare it with the gold standard, the present test, and get all the values. If you find it's got a good accuracy, that means more than 90% sensitivity, specificity, then the test is valid and can be used for practice. This is what we have done one study, prospective evaluation of diagnostic performance and new H. pylori stool antigen kit. And these are the results what we got, sensitivity, specificity, NPV, and accuracy, overall accuracy. So now we've seen observational studies. This is just an overview. It's not possible to cover everything. So I'll just touch upon what is interventional studies, which gives the highest level of evidence. The randomized controlled trials, what we call it as. This is what is the approach. We can get temporal association, consistency with causal relationship, and magnitude of correlation is high when compared to observational studies. Clinical trials in hospital studying, it can also be called field trials. So these are classified as randomized controlled trials, where you have a planned experiment where you actually divide it and give an intervention, and the control arm is there. And this is randomized. So all the patients have equal chance of going into an intervention or control arm. This has got the least bias, randomization, blinding, and attrition control that decides it. Can be individual randomized controlled trials, what we have the hospital base, or the whole hospital can be actually classified into one of the interventions. And that is called as cluster trials. But before we do the trial, that uncertainty and equipoise is necessary. You cannot do a randomized control interventional trial when the answer is already established, as it was told by the other speakers, that once you have a reply and an answer to a research question, there's no point actually doing this. These are different designs what you have: parallel arm, crossover design, equivalence trials, factorial designs. So this is the commonest design that is used. You have actually one intervention and one control. Basically the intervention is compared with the standard of care, which is the control. Sometimes, rarely, we use both as interventions, what we call head-to-head this thing. Those are called as equivalence trials. Crossover design, not commonly used in surgical practice or factorial design. Based on the hypothesis, now some examples I'm going to show of ERAS protocols. We just now did a panel discussion on ERAS. So most of the times we'll take a outcome as the stay in the hospital, length of hospitalization. So if the ERAS arm has better than the control arm, we say that it's a superior trial. But suppose in the same ERAS study, if you want to compare the complications, whether in ERAS arm we get more complications compared to the standard, then it can be also classified as a non-inferiority trial. So no worse than the existing standard treatment. This is based on the hypothesis. So this, you can see this is a randomized controlled trial published very recently, it's the last year. Efficacy of pregabalin and antioxidant combination reducing pain in patients with chronic pancreatitis. This is a study design given. Single center prospective. Actually, for RCTs, prospective is not mandatory to put parallel arm, 2 arms, double blind. It was double blinded, randomized controlled trial. So this has to go practically into the title, an RCT or a double. That's mandatory so that people pick it up when they use keywords. Similarly, for this ERAS protocol, again a randomized controlled trial. Okay, so this is the study design, single center prospective. It's very mandatory all these trials are registered because especially RCTs are not taken in good journals without registration. If you have published articles, then you get invited for writing systematic review and meta-analysis. These are based on RCTs, and this is what we got based on one of the trials published in the past. So there, instead of in randomized controlled trials, we have consort. We're not going to designs or into the details of that. And this is the prisma, what we have for systematic review and meta-analysis. So if you see this particular article, which I mentioned here, this is one of the earliest articles from, this is the only meta-analysis on enhanced recovery after surgery, published in World Journal of Surgery. Dr. Lakshman had given an example of that. And I'm happy to say that our trial, this is the only trial from India which has been included. This is all the forest plot and all which is given there. So how to choose an appropriate study design? Formulate the research question, assess the feasibility. It is very important that you should have the resources to do it. What type of design should be taken? The best possible design with maximum reducing bias. Select, if you want, if RCT is not suitable, select the most appropriate observation design to answer that particular research question. Again, keeping this in mind. So here, if you're not doing RCT, see whether cohort is possible, not possible, case controlled. Otherwise, go down, 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 and select the most appropriate design. When it is an uncommon outcome, case control study. When it's an uncommon exposure, cohort study. In case control studies, although it's a retrospective data, always maintain a good database. That's called as prospectively maintained database. If that is maintained, then even from retrospective studies, you can give good answers to the resource limited settings. Because cohort study might be difficult. We can heavily depend on the retrospective design. Ethical issues are the major problem. Just now we had Dr. Ramanuj mentioning about the ethical issues in the examples what he gave. In those circumstances, naturally RCTs become a big problem. So better to design, better to depend on observational studies. Observational studies, immediately the ethics committee will pass it off because observation, we are a bystander and not doing anything. So the key points for this particular talk is study design in medical research can be broadly classified as basic, observational, and interventional studies. Observational studies can be divided further into descriptive, no comparison, or analytical studies where you have comparison. In analytical studies, we have case control studies where we proceed from outcome to exposure, whereas in cohort study, we proceed from exposure to outcome. RCTs can be divided as parallel arm, crossover, or factorial designs. As I said, most commonly done RCTs anywhere in the world, even if you take any JM, New England Journal of Medicine, most of them will be parallel arm only. And of course, you have to decide whether you want to do you have to take a superiority design hypothesis or a non-inferiority type of hypothesis. However, the keystone in the decision-making process for suitable study design is always, you should keep in mind, reducing bias should be the prime factor. And of course, increasing efficiency. You should be able to complete the study. You have to have the judgment of the local resources available. So I can say that although RCTs and controlled cohort studies provide higher level of evidence, what I was telling about propensity score matching, the best study design is the one that answers the research question more explicitly. Thank you very much for your kind attention.
Thank you very much, Professor Kate. It is almost unfair to give you 10 minutes to cover a topic like this, but I must say that you have done an exemplary job. Obviously, because of time constraints, certain aspects could not be explained in great detail. But what I would like to impress upon our young surgeons here and the postgraduates is that some degree of statistical knowledge is important. You will note that Professor Kate talked about propensity score matching, ROC, odds ratio, and the like. So some working knowledge of what these things mean is important, and I would urge you to spend the time and effort to learn the basics of these statistical terminology. We come to the last presentation of the panel today, and this is about writing up a very basic document that is required for not only ensuring that you stick to your methods as you have designed it yourself, you would also need it for ethical committee clearance and certain other funding if you're going for it. So it has a lot of uses. And so before you start your actual project, you need to have a protocol. We have Professor Pavanendra Lal talking to us about how to draw up a protocol. Professor Lal, please.
Very good evening, Dr. Lakshman, and to my colleagues, Professor Kate and Professor Ramanuj, and to all of you here this evening. Greetings from my institution, where I'm back now from my role in the National Board as the head of surgery, my first love. Because of the increasing clinical work, I had to excuse myself from the commitment at the National Board. And so in the next few slides, I will go through why we need a protocol, why is it very important, what are the steps before writing it, what are the various components of a protocol, and is protocol the mirror of your thesis research? So what is the protocol? Well, if I see the dictionary meaning, it is a system of rules that explains the correct conduct and procedures to be followed in forms and situations, in formal situations. And it is also defined as a plan for a scientific experiment or for medical treatment, or it is a document that describes the details of a treatise or a formal agreement between countries. And so the one in yellow, the middle one, is what we are looking at as a protocol for the purpose of medical research. So protocol is actually nothing but a proposal for your thesis. So when you are introducing your research work before the committee, which is going to approve your topic, protocol is the document that is going to do it for you. So no research has started without a protocol being written, being presented, and being approved. So it actually introduces the research topic. It needs to outline the recent relevant research and literature as applicable to the topic. So it should not be just anywhere else. It should just be focused to the topic that you want to do the research on. It should specify the problem and the objectives, what you want to attain at the end of your research work. And many of those things have already been covered by the preceding speakers. And it should be able to describe the methodology and the statistical methods that you propose to use in your particular study. So aim is to convince the department or the institutional committee that the research is actually worth undertaking, and it serves as a guide to elaborate the thesis upon. So basically, it is really the mirror of your thesis work. What are the components of a protocol? It starts with an introduction. There is then a component of lacuna in current knowledge. Then it comes to the aim, where you have to define what is the primary endpoint and the secondary endpoint. Then you have to come to the methods, which says about patients and methodology. And then you have to mention what statistical tools you will be using to interpret the results that you get from your study. Finally, you need to mention the follow-up, and you need to put some annexures along with the protocol, which is sometimes mandatory, and we'll touch upon all these in the next few slides. So most important component is the topic, and topic is the one which you choose. We have seen how Dr. Ramanuj told you examples about how to choose a topic. It depends on the patient material that is available to you. It depends on your choice as your research interest, but very importantly, there is a rate limiting factor, and that is the guide or the supervisor who is supposed to be mentoring you. You cannot do a research if your guide does not perform that operation or does not believe in the topic which you bring to him. So it's very important. All these things become very important when you make a topic. Now, topic is usually a null hypothesis. When you say null hypothesis, you say when you're comparing two items, there is no difference between the two, is the way to say, whereas actually you want to find the difference. So a positive hypothesis is a hypothesis, but when you say there is no difference between the two, it becomes a null hypothesis. So it's the reverse of the hypothesis which you want to prove. After you have written a topic which gives the elaborate purpose of your research work, as has been defined by Professor Cartes in his various topics that he showed you, you have to write your aims and objectives. Aim is the intention of what you hope to achieve. Aims and objectives are not the same thing. Objectives are the steps that you take to achieve the aim. So they are not one and the same. Sometimes people think they're one and the same things. So whereas aims are broad, objectives are specific because they are steps towards the aim. So we use what is known as the SMART mnemonic. That is, it should be specific, measurable, achievable, realistic, and time constrained. So you should not make just anything. We know normally your research topics when you're doing for your postgraduate thesis are defined by the duration of your PG protocol, which is 1 year or 1.5 years. So you need to have a definite time. You can't have something which can be done on 5 years because you'll be gone. And you have to finish your work before that. It also refers to the primary and the secondary endpoints of the study. So this is very important. Primary objective or endpoint of a clinical study is the endpoint for which the study is powered. That means the number of cases that you took for your study will be able to reach the primary objective or endpoint. Whereas the secondary objective or endpoints are the additional points, extra points, where which may or may not be pre-specified, but it is not necessary that your study or trial should be able to do it statistically relevant for them. So whereas the primary endpoint should be statistically achievable by the number of patients that you choose in your study, the secondary endpoints are extra points that you gain. So what is power of a study? It represents the probability of finding a difference that exists in a population based on the number of study population that you choose. So adequate number of patients in the study based upon the available public research is the way to use the power, and there are many formulas. And when you decide your study, you have to go to the statistician, you have to go with the published literature in that particular field, and then the statistician will use a couple of those very complex formulas and say, hey, for this, you actually need 1,000 cases. Oh my goodness, I can't do 1,000 in 6 months' time. Okay, so you will say the actual number is 1,000, but for the purpose of the thesis, I will be taking only 50 cases because only I can then achieve this. So that you will then have to put it down as a caveat at the time. Then we come to the methods which tell about the study design, that it is prospective, randomized, what is the study duration, what are the materials, which is actually the patients. And when they are patients, you therefore have to say how you will include them in the study. So inclusion criteria, how you will not include them, therefore exclusion criteria. What should be the sample size based on the powering of the study? What are the various methods? You outline them, tell about the preoperative workup. If there is an operation involved, give some details about it, write the follow-up of the patient after surgery, and say for how long you would like to follow them up for a few months for a feasible period so that your primary and secondary outcomes are measured. And then you will be going to the statistical analysis, which is comparison of using techniques. Generally comparing the two groups, you need to do statistical analysis. So you need qualitative versus quantitative data comparison. So for example, if you have to find the significance of difference, you will have to use student t-test or a chi-square test to find out whether you are doing a difference between a qualitative data and a quantitative data. If you're doing correlation, then you might have to use Pearson's coefficient of correlation. And if you're using some software, you will have to make a mention. So some idea about statistics you will need to learn. It's a purpose of a thesis work to allow you to learn some nuances of statistics so that when you interpret your other papers, when you become a mature surgeon, you can make some sense out of those. Then you go to the last part, which is references and annexures, which is usually a single page. Usually we say they should be less than 10 for a protocol. They should also have in the annexures detailed consent in the local dialect. For example, we are in North India and we need to have consent in Hindi language. In addition to English language, there has to be a patient pro forma for each case. So you need to have your, each case pro forma sample there, and then some sample master chart. So everything the committee is going to see how you are going to collate your data together to make sense out of it. And this is, an example of my own first thesis work, which was given to my student, who was Ramkrishan Kajla, who is the second author. And this was a study which we did as a RCT between TEP and Liechtenstein open hernia. And I'm very glad Ramanuj picked up this particular problem. And this was a very new topic 22 years back, 99 we started this. And we did not think that this will reach surgical endoscopy one day. We had only 25 patients in one group. So I want to tell you, numbers are not important. It is the integrity, eye of the 8 eyes, which previous speakers told and Dr. Lakshman spoke, integrity of the study. I think this was integrity of the study that we submitted it on 18th of November and it got accepted within 2 weeks on the 5th of December and it got published. It is the first RCT from India on TEP and open hernia repair ever. And you can see the citation. It went on to be cited. It is being cited everywhere. It entered textbooks, including Sabiston and huge hernia books. We had no intention that it would do it. It was that PG thesis of Ramkrishan Kajla, who is now a professor of surgery at Medical College in Bikaner. So you cannot know how your study can go up. You just keep your eyes and be truthful and keep doing it rightly. So to summarize, delegates, dear friends here, protocol is actually the mirror of your thesis. It is the framework on which the thesis is performed and written. Therefore, all the inherent steps in writing it are very, very important. A badly framed protocol would lead to a badly done research and a badly written thesis and a badly written research work. So please ensure that your starting point, that is the protocol, is well written, because when it is well started, it's a job half done. Thank you very much for this opportunity, Dr. Lakshman, and to the organizing committee of asicon for having me included here today, along with this esteemed panel.
Thank you very much, Professor Lal. I think it's our privilege to have somebody as knowledgeable and as accomplished as you on the panel. We don't have any questions on the chat box, but we still have a few more minutes, and actually only 5 minutes. But I have one important question to ask of all of you. Perhaps all of you can speak for a minute about it. It's an uphill struggle to motivate a youngster to do anything other than read up a textbook and operate on the patient. One step beyond getting a research, a thesis is seen as a chore that has to be done. It is a bitter pill to swallow for most of our postgraduates, and it's a job motivating them. Ramanuj, what would you do to encourage and motivate your students?
Sir, I think that particularly in surgery, we follow a discipline, and hence before, say, changing students, I would like to change my junior faculty. So like assistant professors becoming associates and becoming research guides. So the basic problem probably starts on that if the guide does not have a queue, or the guide is not interested in doing the research, that translates usually to a very badly done thesis, which is usually a copy-pasted thesis from a previous one. So I think the first thing, and it was as I've shown in one of my when the National Medical Commission introduced the mandatory basic research in biomedical research, the fundamentals of research, I considered it as a very, very welcome move, because with the low and the poor quality and the bad science that goes on with the research in India, I think guiding the guides will be the first step to a good research, who can then understand what is the importance of a truthful and an ethical research, and then they can motivate a young student to understand that, yes, this is how you should proceed.
Professor Kate, sir.
I will give the example what Professor Pal has given and Prof. Lal has given. So he has actually had a student's paper, PG student's paper published in a reputed journal, and that paper has now come into Saviston. So if I have to give a choice, I will give an example of this sort of a paper and tell that this has been written at a postgraduate level as a part of the thesis. Because I feel that basically the students will always equate themselves and learn from their peers. If I show them my paper, my research, they'll never get influenced. They always feel that at their level, how they can accomplish something. So what Professor Parminder Lal has shown, that if you just project that sort of thing when you're actually discussing protocol, this paper was published 20 years back and this is the outcome and this is what the patient has received. I think that becomes a very big motivating factor and a stimulation. We've also got some of our thesis students, like we have actually right now in Delhi, it's going on, the SSAT is going on. Tomorrow we have a launch in India. So last summer in May, one of our same PG thesis protocol, not protocol, a paper, it is published in Journal of Gastrointestinal Surgery. It has selected in the top 3 papers in the SSAT, in the Digestive Disease Conference, the largest conference in GI in the world. And this is the first time, I'm not saying an Indian paper, an Asian paper has been selected in the last 16 years in the resident fellowship category. They have 16 years. No paper from whole Asia, where we have Japan, Korea, everything has got selected. So it becomes a big stimulant. It becomes a big stimulant. You just project that photograph and show it to the PGs. They automatically get stimulated. They will not contact us. They will contact that student, how they did, what they did. And right now, I'm very proud to say that now, actually, asicon is a little virtual, but when up till Bhubaneswar conference, all our students who are postgraduate students in the final year and they finish, usually we finish our exams in 2nd week of December, your MS exam. They would be presenting, everybody would be presenting the thesis paper in asicon.
Very nice, sir. Thank you. Thank you very much.
It becomes
excellent. Sorry, we've run out of time. I'm afraid I can't give you a minute, Professor Lal, because as a very last remark, I would like to thank all of you, Professor Lal, Professor Mukherjee, Professor Kate, for giving us an excellent exposition of what research is all about. And I do hope that our youngsters have benefited from it. I would like, on behalf of all of you, to thank ASI, Dr. Dalvi, the president, Sanjay Jain, the secretary, and head of academics, Santosh John Abraham, for giving us this opportunity. Thank you very much and good night.
Thank you.
Thank you, sir. Thank you for doing it wonderfully for all of us.